Good afternoon, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, and I'll be your moderator. Dr. Dan Butterman joins us as our speaker today, as he will discuss digital implant workflows and specifically the benefits of transitioning from analog to digital. Dr. Butterman is a fellow of the International Congress of Oral Implantologists and is also a resident faculty at cdocs.com. At any point during the webinar, if you have a question, please type it in the Q&A section of the control panel, and we'll answer it live at the end. Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand, and this webinar is sponsored by Dentsply Sirona. So with that, Dr. Butterman, the floor is yours.
Thanks, Adam. I appreciate it. A couple things. First of all, thanks for joining me for this webinar. Just a little bit more about me. I have a private practice in Centennial, Colorado. I typically work 3.5 days a week doing traditional dentistry, mostly on the digital side. I'd spent a lot of time placing and restoring implants and CAD/CAM dentistry in general. Aside from my private practice, as Adam mentioned, I also teach for CDOC, so I spend at least 2 to 3 times a month lecturing and speaking about CEREC, about implant placement and restoration, again, on a digital format. And then lastly, my other full-time job is a beta tester, mainly for Dentsply Sirona, but for other material companies as well. I test hardware, software, materials. And really the point of all of that is that it really gives me a very deep understanding of the direction that the software and hardware and materials are going to be going, because I generally am going to have access to things maybe a year to 2 years in advance of release. I can see what's working, what's not working, and I kind of can have a feel of what direction the entire market's going to be going in. And it's really helpful for me from a teaching perspective because it lets me sometimes share some of that with you guys. Now, a couple things about this webinar in particular. I've done a number of them, and on this one, we're really going to be focusing more on digital imaging as it comes to implant placement and restoration. And we're going to be outsourcing and talk about outsourcing to a lab for the manufacturing process. But understand that everything that I'm going to show you and everything that I'm going to be talking about really could be done in-house as well. Not only could it be done in-house, but these are things that I have personally manufactured in my office for use. So for those of you that are watching and considering just digital imaging, well, that's great. All of this can be done with digital imaging. If you and then you would certainly partner with a laboratory if you decide eventually to move into a manufacturing process as well. Well, that still applies because you can incorporate all of these sort of things. So to highlight what we're really going to be discussing today as far as digital imaging is concerned, I want to talk about the CEREC Prime Scan in particular. I'm just going to take my image real quick and make it a little bit smaller so that I can get out of the way. So CEREC Prime Scan is, although the hardware isn't new or relatively new, the actual software has been continuing to improve. And I'll show you in a minute, this was the most accurate scanner on the market. It has now become even more accurate with some of the changes to the software that's available. There's really 2 versions of this machine that you can look at. One is basically a Connect unit or a digital imaging unit that would allow you to acquire all of the images, and the sole purpose is to send those images elsewhere to a laboratory to manufacture, to design. With the change of a license key, you can eventually decide to get into manufacturing, and you can switch this over to a full CEREC machine, meaning that not just imaging is available to you, but actually design and manufacture as well. So kind of keep that versatility in mind as we talk about this. One of the really nice things about the Prime Scan in general is that you don't have to just image teeth. It's a scanner. It's a 3D image scanner, and you can really pick up anything. So, in my office, there's a huge advantage, especially on the implant side of things, to be able to take a patient's denture and just image it. And once I image it, I now have a 3D model. As part of the imaging systems, you have the ability to export these files as an STL. So if you happen to have a 3D printer, then you have the ability to take a patient's denture, image it, and capture a perfect 3D replication of that denture if you want to then send it to your 3D printer, and then you have a denture that you've duplicated. And this could be used certainly for doing impressions for denture patients, or for doing scanning if you're going to be doing a full arch or hybrid kind of case and incorporating that with CBCT. So a lot of advantages to just being able to pick something up and image it. The other questions that I get asked a lot are, how accurate is this for full arch scan? Well, it's really designed for full arch scan. To do a full arch scan, you can do it, and that lower arch there was probably done in about 30 or 45 seconds to acquire all of that. Do you need to worry about shiny objects like gold? No, it fills that in very, very quickly. And depth of field is pretty incredible. I know we're talking about implants, but really, deep margins are just not an issue, because you're going to be able to image beyond 20 millimeters deep, which is quite significant. Just as an example for that, this was an implant case that I imaged recently. And how deep can you see into that? You can see all the index in the implant, but if you flip that over, I was actually able to image all the way down to the bottom of the screw channel. That depth of field is incredible. So do you need to worry about when your margin on a tooth prep is a few millimeters subgingival? Of course not. I can image that deep, and that depth of field is what's going to allow us really to fill in and capture anything. I alluded to the fact that the software sort of constantly improves, and it's kind of cool, in my opinion, to be able to own a piece of hardware that over time just gets better. And it gets better because of software improvements. And this is a perfect example with the 5.2 software coming out onto the market and launching very, very soon. What we have been able to see is that imaging, the data that's acquired in imaging, the 3D data points are now being acquired at twice as fast. So it's incorporating 2 times the data, which means that I can scan twice as fast. And the data points just become insanely good, and the accuracy just goes up from there. Couple other features when it comes to imaging, and don't worry, I'll get into implant workflows as well, but I just need you to understand what imaging involves, because it's not just taking a 3D picture. We have the ability to do 2D imaging as well. So with 2D imaging, I've got an intraoral camera. Basically, I can capture pictures of anything that I want. They could be still JPEG pictures, and I can export them as a JPEG, or this could be a movie. And I can just capture a movie of my patient's arch, and that's something that they can visualize for co-diagnosis and conversations that we can have about treatment planning. So just taking a look at real-time scanning, for those of you that haven't seen scanning happen with a prime scan, this is just my typical workflow. Now, this is with teeth, and you'll see in a minute with implants. I'm going to image the upper arch, and you'll see approximately how long it takes. All this is in real time. So typically I'm going to do a linear scan technique, where I start on the occlusal, and then I roll around to the lingual, and then I come back along the occlusal surfaces of the teeth, and then we roll over to the buccal, and we fill in the buccal surface of the teeth. So this is acquiring lifetime. And what you'll notice in a little bit when we do the lower arch is that it's going to be able to retrieve and remove artifacts as well that get in our way. So we just imaged the upper arch. We'll now do the same thing on the lower arch, and we'll start scanning here. And you'll see that as I'm scanning and coming around to the anterior area, we're just going to start to pick up part of that lip. And that's going to be captured, but I'll still do that same linear type of a scan approach. It doesn't matter, because the software is basically looking at the number of images acquired. So if I now move the lip out of the way and I rescan that area, the software says, oh, it doesn't belong here. There are more images without the lip than with the lip, so it'll just take that away. And then finally, for acquiring the buccal bite, quite simple. We just have the patient occlude, and we're just going to capture that data between the upper, and we just need a little bit of common data between the upper jaw and the lower jaw, and we have our scanning complete. So really, this is not a difficult process. This is not something I have an assistant helping me with during scanning. We do need a little bit of retraction for it. It just makes it easier. But this is a simple process to acquire these images. So when we're looking at scanning, especially when it comes into implant placement, and ladies and gentlemen, as we go through this, I am keeping an eye on the chat, and I am keeping an eye on questions. So if things come up, please feel free to interrupt and ask questions as we're going through this. I've designed some time at the end as well so that we can end early and answer some questions with that. But I don't want anything to get left out. So just either use the chat. That would probably just be the easiest, or there's a formal Q&A box for that as well. But as we're looking through this, we have to understand when you're looking at a scanner, there's a difference between trueness and precision with scanning. If we're talking about accuracy as a whole, we need to look at both of these parts. Trueness means I've got a target. I've got a certain level of accuracy that we've got to measure, and I've got that target. How close to the target are we actually going to hit? So is my 3D image true to life? Does it look the same and appear the same as it in life? And then we have something called precision, because these are different. Maybe I can hit it every once in a while, but how often, how reproducible is that level of trueness? That's where precision comes in, and both are important when we're looking at the accuracy of a scanner. So for example, if we want to restore a full arch implant case, then we need to have something that's going to be quite accurate. We want to have a passive fit. So there are some really great studies that are just going on right now. And one of them, really, they've found that if your level of accuracy is 30 microns or better, meaning that your error that you build into your models is less than 30 microns, well, then you're going to have a very accurate passive full arch fit. And there have been multiple studies and some really great ones where they were done on human maxillas to just really get an idea that these are not plastic models. And we can kind of see that level that we are now getting to with the prime scan is basically on par with a physical traditional impression. And I can tell you from, and I'm sure all of you that have done implant full arch impressions, that can be intimidating. And if we can do an accurate full arch scan, well, that speaks to me. That changes things quite a bit workflow wise. This is a study by Dr. Mail at the University of Zurich that was just done. And don't worry about the numbers, but if we were to look through this data, and this was just comparing the trueness and the precision between multiple scanners and looking at it from a complete arch, from an anterior segment, and from a posterior segment, the takeaway from this is that, and this was before the latest version of the CEREC software that we have out to us now, the prime scan had the highest trueness and highest precision. The CEREC OmniCam that has been upgraded with 5.0 software or higher had really good trueness and precision. The older version of CEREC, the 4.6, was not very good for full arch with trueness and precision, but it was quite good for a posterior segment. So it depends what you want to do. If your goal is just restoring small quadrant dentistry, well, then older versions of the machine may be adequate for you. But if you're going to be doing more larger cases or full arch things with implants, then we need to move up in technology and software, and you can achieve those sort of things. So let's take a look at a typical analog workflow that most people are doing in their practices. And this happens every single day. Patient comes in and they're missing a couple of maybe posterior teeth. So you say, hey, Mrs. Jones, have you ever thought about replacing those teeth? And the patient's like, yeah, that would be great. What can we do? So what do? You do what you always do when you're not sure what you're going to do, and you take an impression. So we take an impression, we mount it up, and we send it to the lab, and we say, hey, let's go ahead and get a diagnostic wax up. So the lab will do some form of a wax up. You can do it yourself with denture teeth, but some sort of a wax up is done. That's typically going to take a couple weeks, and maybe it's going to cost a couple $100 to get that done. So you take a look and you say, okay, well, that looks really good. Well, I need to be able to figure out where those teeth are in relation to the patient's bone, and we're going to be taking a CBCT. So then you would ask your laboratory to make some sort of a barium sulfite scanning appliance. So, okay, you send that to the lab and they take care of that. And again, it's going to be another couple weeks, maybe another couple $100 for you to do that. And then you can finally now take your x-ray. And now you can just start to plan after a month and a half has gone by. So now you're planning your implants based on where your teeth are going to be. And you send all that back to the lab and you say, okay, go ahead and make me a surgical guide so I can get these implants where we plan. So by the time we get to this point, we have spent hundreds and hundreds of dollars. We have spent weeks and weeks of time. And really, is that necessary anymore? And I'd say that That kind of a workflow just doesn't speak to me anymore. It's just not efficient. It just doesn't make a lot of sense. And it's also not the most accurate type of a workflow. So if you have the ability to do a digital scan, and this was with an older version of the OmniCam, that's why the image looks this way. But if you would just do a scan of the patient's edentulous site, and you take a CBCT, if you have one, fantastic. If not, then you can send your patient off and have a cone beam done for you. And you would just submit that. In this example, and I'll show you a couple of others. In this example, this was sent to Dentsply Sirona. In about 24 hours, they're going to take all of this data. They're going to plan the implant. They're going to plan the restoration. They're going to plan the abutment and give you all of this data back in a day. And then when you say, yes, I'm ready to go, or the patient says, yes, they're ready to go, you're ready for surgery in a week with all the components and surgical kit that you're going to need for it. So that analog workflow it's just not necessary anymore. Just with digital imaging alone, it opens the door to so many other possibilities in the workflows that are out there when it relates to implants. And then impressions. We've all done a standard closed tray impression, and maybe it's just a Denver thing, but every once in a while, I used to take that impression coping and I would seat it back into the impression, and the damn thing would have like a little bit of play to it. How accurate is my restoration? What are the odds that the lab's going to send me back something that needs no adjustment? Well, that's just not going to happen because there is room for error. There's room for distortion in a physical impression. What about a closed tray impression? Well, okay, an open tray impression. So okay, maybe we'll do something like this, and maybe we can improve our accuracy, and we're not going to have to take that impression coping and seat it back into the tray. But we end up doing stuff like this. That's a very intimidating appointment. It's intimidating for the patient, and it's intimidating for the whole team because everybody knows that thing is not coming out of the patient's mouth until you can locate all of those screws and you can unscrew the thing, and then your patient's uncomfortable and they're gagging, and God forbid you miss it and you have to redo it. That's just not fun. So in my office, I'd rather take a picture, and we can do this with full arch. We can do this with single implants. We can just apply something to the implant, just like you guys are doing with a physical impression. It's an impression coping, just like you use, except this is an optical one instead of a physical one. And we're just going to take an image of that. This is going to allow us to capture tissue contours. We're not going to have to wait and worry about tissue collapsing while we're doing our impression, while we're waiting for it to set for 5 minutes, because this takes seconds. And it's going to give us something that is the most accurate out there. So if we're talking workflows, and really that's kind of what I care about when it comes to implants, I don't really care about parts and pieces. I care about an entire workflow. And I just want to mention this one in particular because this is one that I've used quite a bit in my practice. I actually alpha tested this one. It was a concept, and then beta tested it all the way through to release. So I know quite a bit about this concept. But the cool thing about it is, again, you don't have to have the ability to manufacture anything in your office. Really, the only thing you need is digital imaging for this. So it is basically an entire implant planning, implant surgery, and implant restoration in a box. So let me just spend a little bit of time talking about this. So the premise is, again, I'm going to take an optical scan of my patient. I'll do now I would use a prime scan of the edentulous site. It doesn't have to be an edentulous site. It could be a site where we're planning to extract a tooth and we want it virtually extracted. And then we're just going to take a CBCT scan, and we're going to send those two pieces of data to Dentsply Sirona. They are now going to plan the implant position, but it's going to be based on the restoration. So they're going to do this as a crown down approach so that we can have ideal contours and that our implant is going to line up properly with the final restoration in mind. Once I have approved that plan, and again, that plan takes about a day to develop. Once I approve it, approximately a week later, this box shows up in my office. So in this box, and I'll just move myself out of the way a little bit here. In this box, we have all the drills that you need for the surgery. So you don't have to have a surgical kit. You've got the implant that you've approved. You've got the surgical guide that's been manufactured. And then there's two really interesting other features. You have not just a stock healing abutment, you actually have a custom healing abutment. And then you have a final abutment and a plastic PMMA temporary crown. So you can make the decision at time of surgery, what do you want to apply? Are you going to put a healing abutment on, or do you actually want to temporize the implant at day of surgery. And those are all options in the box. So patient comes in, we perform a guided osteotomy and guided implant placement. Now, the trick for this and the reason that it works is because we are not just measuring and recording our depth of our implant with the guide and our angulation and position. We're also measuring and making sure that our rotational position is accurate as well, or our timing of our implant, because that's what's going to allow me to have the prosthetics made in advance. And then basically what's going to happen is that there's an index on that driver. I don't have it pictured here, but that index on the driver, or notch on the driver, is going to line up with a notch or an index on the surgical guide. And where those two pieces meet, then you know your accuracy is there. So again, I've got these two things in the box. I've got a custom healing abutment, and then I have a final abutment with a temporary crown. And the cool thing about this is look at the contours of that abutment, the healing abutment and the final one. They're identical because they're based off of the same digital file. So what's the advantage of that? Look at it the way you used to do implant surgery. You take a 4 millimeter round healing abutment and you put it on at the time of surgery, and the patient goes away for 3 months and then they heal up and they come back. When you unscrew that healing abutment, what does the tissue look like? It's a 4 millimeter round circle. It's not a coincidence. It's going to heal to whatever the shape that you apply to it. So if you're going to put something on the day of surgery, why not have something that's exactly the shape and contour of your final restoration? So that's the premise behind having a custom healing abutment. So patient leaves, and this is literally just picking up the temporary and the final abutment and screwing it into place. Those of you that have made temporaries at time of surgery, you know that just making the temporaries is going to take you longer than the implant surgery by far. And that's a major reason why we may not want to temporize it. That's why we're a lot of times using flippers and Essex retainers. Of course, there are other reasons as well, but that is certainly one. So if it's just sitting on my tray, that's just a great ability to be able to pick it up and use that. So the patient leaves, and then as part of this, I'm going to have the virtual abutment. And so basically, this is the abutment that the patient has in their mouth. And sitting behind me here, that virtual abutment is something that I can now forward to my lab. I can say, hey, you know what? Here's the abutment as if I took an impression. I want for you to design a crown. So design it, mill it out, and send it to me. So now when my patient heals up and they return, all I have to do is take off their temporary and I can place my final restoration. And all of that can be done behind the scenes. Again, this is something that if you have the ability to mill or manufacture in your office, well, you can just do it in your office. You don't have to send it to a lab. If you were just doing digital imaging, then this entire workflow would speak to you and be able to be something that you could be done. So let me just walk through an actual recent Azento surgery, or not quite so recent. This one was from about a year ago. So patient comes in and it's a lateral tooth number 7, and the root is fractured. There's a post in there and everything's moving. So I send my optical scan, I send my CBCT scan, and the Azento or dentsply Schein implants is going to plan everything. Now, on this particular case, because of where the implant had to be planned, the screw access channel was coming out through the facial. One of the really cool things with this system is that you can angulate it back up to 30 degrees. So if you say, hey, I love doing screw retain restorations, I don't ever want to cement a crown, well, no big deal. They can take that and they can rotate it back the way they did here to have this as a screw retain restoration. They're also going to send you a recipe. So this recipe is going to show you the exact sequence and drills and tools that you're going to use for the surgery and how all the components are going to come together. And then this box shows up. Inside this box, as I already mentioned, you've got all the drills, you've got the surgical guide, you've got the custom healing abutment, and you have the final abutment with the plastic PMMA crown. The core file or the virtual model that you're going to send to your lab afterwards will come to you in an email. And you just forward that to your lab and they can manufacture the restoration from there. So day of surgery, we're doing our guided osteotomy, and then we are placing our implant. I'm watching the rotational timing and I'm making sure that I have everything in position here. So this, as I mentioned, even though the screw access channel was coming through the facial, I had them angle it back to the lingual so that, because I don't really love, I don't love cementing restorations to begin with around implants. I certainly would do it, But at the time of surgery, I certainly don't want to cement anything. So I need this to be screw retained if we're going to be placing that on there. Patient's been given instructions that this is for smiling only. When I place this temporary on, I always err on the side of making them too short. So I actually ground down that incisal edge just a little bit so that the patient couldn't function for sure on that temporary. So now the patient leaves and they return about 3 months later, and the implant is integrated and everything is looking good. So on this particular case, because, and you can kind of see it a little bit here, we got a little bit, this was an immediate extraction, and the implant was placed and a temporary was placed on. We got a little bit of tissue recession right on the distofacial, and I was able to see my abutment margin. So I didn't want to just have a core file. I didn't want to have just a final restoration made for that abutment that was sitting on there. I wanted to have a new abutment made. So I just took off, I just unscrewed that temporary that was on there, and I just did new images. Again, all I'm doing is using my prime scan for digital imaging. I will use, and I'll talk more about this, this is an IO flow. This is a scan body designed to be sent to Atlantis, because Dentsply Sirona is the company that will make Atlantis abutments, and they also do Azento. It's all the same company. So I can send that to them. And then they're going to send me an email, and they're going to say, hey, here's the abutment that we're planning to make. Are you good with this? And if I am, great, I can just approve it. But I have the option to open up an editor. And this is on Atlantis's website. This is not with my imaging. This is not anything that I'm using on my equipment. So I'll just log into their website. I'll take a look at this abutment, and now I can start moving margins. I can start changing contours. I can adjust anything on here to what I like. And as soon as I hit approve, then it goes into manufacture, and then they will automatically create that core file. Again, I took that core file in my office, and I designed the crown on my CEREC, and I milled it out, and I made the final restoration. But you have a couple of choices. You can either take that core file and say, here you go, here's my favorite lab, I'm sending you, and they will create this core file in many different formats. So your lab doesn't even have to use CEREC. They can use any other system that's on the market. And so the lab can design this, they can manufacture it and take care of it. Dentsply Sirona Implants or Atlantis can also make the crown for you if you choose, if you ask them to do that. So we've removed the temporary, and we now have the new abutment that was been made, and we've torqued that in. And then here is the crown that was designed and manufactured, and it looks pretty good. Now, in all honesty, this is the second crown. I made two for this patient because I had the core file, I had the ability to do that. Kind of a big advantage of milling it in-house as opposed to sending it to a lab, because the cost of a block for me to make a crown was about $23. So, well, I'll try and two. And I just chose the one that I like better and that the patient liked better. And I threw this in because the patient literally just came back yesterday for his 1-year post-op, and it looks really good. The tissue looks good, and the color match and the aesthetics are good here. This is the kind of stuff that would potentially cost a lot of money to make, but the cost of that abutment that Atlantis made for me was about $200. The cost of the crown, since I made it myself out of the block, was about $23 or $25. Your lab, if you send them a digital file, well, they're probably charge you quite a bit less for it than they would if you were doing a physical impression. But the fact that we can get these kind of results at this kind of a price savings is pretty phenomenal as far as I'm concerned. No question. So either you guys are all sleeping, you're bored, or everybody has already logged off. But feel free to jump in with anything as we're going through here. Let's talk about another workflow. Another option, again, because for me, this all comes down to workflow. It doesn't make any sense for me to talk to you about an individual product like the Prime Scan without showing how do I use it in my office and what do I do day to day for this. So if you don't want to do something like Azento, or we're doing a bigger case, well, this is something that could be sent to CCAT. If it's coming to CCAT, the workflow is slightly different. So here you can see we've got a bridge, we've got a 4-unit bridge, and we see this all the time. The anterior tooth was fractured and was disconnected from the bridge. The posterior tooth had quite a large vertical fracture as well, and there was an abscess. So we were going to be losing both of those teeth. Now, I didn't feel like we needed to take this all the way back to tooth number 18. I wanted to do just a 3-unit bridge instead of a 4-unit bridge. We didn't need that. He didn't have anything opposing, quite honestly, that terminal molar there. So here's the workflow. We did a scan, and we can see his bridge from 18 to 21. And so I just took that optical scan. I took his CBCT scan and I sent that to CCAT. And I said, let's make a surgical guide and let's do the surgery. So they will virtually extract those teeth. They'll virtually extract the mesial tooth number 21. They will plan and position the implant at site 18. At site 19 where I was planning to do it, and 18 was just going to be extracted. We're just going to be removing that and not putting anything in that site. So I click on in the software that you're looking at, by the way, I have an Axio CT scanner, and with that, the planning software that I use for that is CCAT 2.0. So embedded within CCAT 2.0 is the ability to plan implants, or I can take those plans and send them to CCAT. If I'm manufacturing this in my office, then I also have the ability to design a CEREC guide. This would be the same software platform that I would use to actually manufacture a guide in my practice. But in this scenario, we just took this and we just submitted this to CCAT through the CCAT 2.0 software. I'm going to tell them the implants that I want positioned and line everything up the way that I want. And the great thing about this is once I send it to them, CCAT is going to be a second pair of eyes. And they're going to take a look at all of my implant planning. They're going to say, hey, do you think you might want to try a wider diameter implant or a longer implant, or change the angulation to this, or your drill path is going to run into trouble, or your surgical guide is going to have issues, the patient may not open wide, because basically they're looking at everything and they're going to email me back and give me choices if there's anything I want to change. And then we come to an agreement. Yes, we're good to go. And then they will do one of a couple of things. They can manufacture the guide and send it to me. I know a lot of you have 3D printers, as I do in my office. So if you have a 3D printer, you can just say, you know what, don't send me the guide, just send me the STL digital file of the guide. So they're going to send me this recipe. They're going to send me this plan, and we can put all of this together. And then this is just the STL file from CCAT. So once I have that, I can just send it to my printer. I can use surgical guide resin for this, and I can print this out. The cost for me to print this, the actual design file from CCAT is about $130, $120 to $130. And then for me to print this on my printer is about maybe $3 or $4 of resin, and I can manufacture this within an hour or so. So here's our patient. This is our bridge. We're going to section the bridge first, and I left tooth number 18 in position. Even though I'm planning to extract it, I left it to help support the guide. So I told CCAT, hey, I want you to virtually extract the other teeth, but leave that one because it'll help support my guide. So the implants are placed. These are 2 Astra EV implants. We just did a very, very small flap for tooth number 19, and no flap where the extraction was happening for tooth number 21. And then the implants go in. And then once the implants are in, now I can extract the molar that we're not saving. So again, I want to have a custom healing abutment. I want the tissue to shape and be shaped rather than just a stock healing abutment. So at the time of surgery, I'm going to be doing imaging. How many of you would feel comfortable doing a physical impression on a surgical site like this? Probably most of us would not, but I'm totally fine to do an optical impression. I'm just taking a picture with my prime scan. And then the scanning abutments or the IO flows come out. And then I just for a couple of days, because it takes about 48 hours for the custom healing abutments to come back, just for a couple of days, the patient will have their regular healing abutments. I just barely hand tighten those just a little bit. So now this goes to Atlantis, and they're going to design for me the custom healing abutments. Again, I can open an editor. I can adjust these. I can change any of the contours, play with any of that. And then I have the ability to have those manufactured in about 48 hours. So the patient comes back, and this was after they fully healed, but they come back for their post-op where I'm removing the sutures, And I'm just very carefully taking off one and tightening these into place. And we still haven't had, it's been short enough time that we're still not getting bone remodeling within the first week. So I'm not worried because these implants torqued in quite well. I'm not worried about putting just a little bit of rotational pressure on these because they still have primary stability. They haven't lost that. We haven't had that dip that happens at about 2 to 3 weeks when we start shifting from mechanical stability to osseointegration. But once this patient comes back, we now have tissue that's healed up nicely and is healed up to the shape that the final abutments are going to be. So now I can remove those final abutments or those temporary healing abutments, and we can re-image. So patient comes in for imaging, and if we're doing for a bridge, it's basically the same idea. I'm just going to place those IOflow scan bodies on top of there, and we're just going to capture all of this. Obviously, we have 2 implant sites, so we're just using 2 IOflow scan bodies. I'm making sure that I'm going to capture my contacts on that canine so that everything's going to fit properly. And we're really just looking at that flat surface. You can see as it's rolling around on the lingual, that flat surface is what is going to allow the software to understand the depth and rotational timing of that implant. So we're just going to fill all of that in. Now, I'm only showing you the imaging of the IOflow scan bodies, but obviously we would do the same thing. We would also image the opposing arch. We would image the buccal bite as well and just kind of capture all of this data. So now I send the case back. And this goes back to Atlantis. I said, hey, those custom healing abutments you made, well, now we're making the final abutments. So again, I have full control. I have editors. I can decide where my margins are. I can decide what these contours are, or in this case, I just said to copy the contours that we use for the custom healing abutments. And we can kind of get a good visual of how much room, if we're going to have to adjust anything for the occlusion here. And then, as I mentioned before, this core file now is something that I can send to my lab. What's the advantage of sending a core file to the lab? Well, if I wasn't doing that, I would have to get the abutments back, and I would have to have my patient in, and I would have to have a new impression, and that would go to the lab. So that saves me a whole appointment. I can basically simulate placing these abutments into the patient's mouth and doing an impression. I don't actually have to do that. These abutments have been virtually placed into the patient's mouth, and it's to the right depth, the right contour of the tissue, because we just imaged this a short while ago. And now either me or the laboratory is going to have that model, and you can design the bridge. If they're doing traditional techniques in a lab, they can print this out, and they can design this off a printed model. If they're using a digital platform, well, then they can design this digitally and mill it out. So here you can see this was done out of Katana zirconia, and those are the couple of abutments that Atlantis sent back. This was the bridge that I milled out, and the cool thing is that this stuff just fits together. I'll spend a bit more time talking about Atlantis in a minute. This is just a insertion guide, so it allows me to take those abutments, and that's one of the things with multi-units, right, is you get one abutment in the right orientation and the bridge isn't going down, and you're not sure if you get lined up the rest of the abutments in the right timing or right position. This insertion guide is super cool because the way it works is it only goes in one way. The abutments go into the insertion guide that goes into the mouth, and then you torque these in so that you ended up with things in the right position. And then finally, we have a perfectly passive fitting bridges. And these fit incredibly passive because the accuracy, we're under 30 microns of error with this. The accuracy is probably better than I can get on a patient like this that gags in a big tongue and full of saliva. It's probably better than I can get with a physical impression. And again, it just made my life and the patient's life just quite a bit easier. So let's just end with the implant restoration components, and I'll just mention that briefly because for me, aside from surgery, when it comes to restoring implants, I really have 3 options. I can do a stock abutment. Because I live in the CEREC world, I can do a tie-based restoration. I'm not really going to spend time talking about tie-based because that is for in-office manufacturing, but I can do that, or I can do a custom abutment with Atlantis that I've already shown you. Stock abutment, I have no use, quite honestly, for a stock abutment ever. And in my office, I just don't see an advantage. But you could. I mean, I can buy an abutment, I can prep it in the patient's mouth and adjust the margins and contours. And for those of you that have never prepped an abutment in the patient's mouth before, milling, hitting the stuff with a diamond, it's a little bit intimidating. It's kind of like the 4th of July. You've got fire shooting out of the patient's mouth and sparks. You're like, no, it's supposed to do that. So I don't love doing that. But you can send that image to a lab, and the lab can design your restoration. And you're going to have these marginally okay restorations fitting on top of a stock abutment. But I just don't feel like that's a great service for the patient. So let me just show you this patient. And really, this was an implant. And the thing that I like about this case is that she was missing this tooth for quite a number of years. And so if she's missing the tooth for quite a while, and I'm going to be doing I'm going to be doing a punch and not a flap, I'm really not expecting a lot of tissue changes here. So if I'm not going to get a lot of tissue changes, she's been missing the tooth for years, she's probably not really going to have any drifting here. We're going to have a situation where the teeth are relatively stable. So this was time of surgery. Why not do the imaging then? Why not do the final impression at the time of surgery, which is what I did here. So implant has just gone in, and we're just going to go ahead and image all of this stuff. Sorry, my video is starting and stopping here. So I'm capturing the tissue contours first, and we'll capture all of this data, and we'll just let this go in almost real time here, real time for most of it. I'm then going to capture her opposing arch. And again, the implant has just been in. Now, this was a guided surgery, so the surgery only took a few minutes. And so we're going to be doing all of our imaging. Now, I could have decided on this case to image just for the custom healing abutment. But on this case, I figured, well, why not just go to the final? Because again, we're not going to expect many tissue changes from the punch, and I'm not going to have an issue with tooth movement here. So now we're going to do her bite and capture that information. And then the final scan, which I'll speed up just a little bit, will be with her IO flow. So the IO flow that's going to get positioned here, this is specific to the brand of implant and platform. So you would purchase this depending on what brand of implant and platform size you have. And that's just going to screw into place. And now I'm going to image. Again, I probably wouldn't feel comfortable doing this at time of surgery with a physical impression, because I don't want to put force. I don't want to have impression material in my surgical site, but I can certainly take a picture of it. I can certainly image that and capture all of this data. So that's all we're doing, just doing our imaging here. And then we're going to put a stock healing abutment and send the patient home. After I acquire all of that data, I'm now going to, because I own because I'm using a Connect version of the software, a digital imaging version of the software, I'm simply going to scroll up to the top and click on Connect. That's going to open my lab portal. So once my portal opens, I'm going to have access to all the different labs that I like to work with that are going to accept my scans. So what CEREC Connect basically does is it packages up all of those images that I just created, and it's going to transport them to the lab of my choice. So all of that data is uploading. You can see it happening in the background. It only takes maybe a few seconds or a minute or so to do. And once that uploads, I'm going to be able to enter my lab script. So once I click on enter order data, it's going to allow me to choose the laboratory that I want to work with. In this case, this is going to Atlantis. So it's going to be Dentsply Sirona implants that I'm sending it to. And then we're just going to have to put a couple pieces of information about the patient. We can anonymize the name if we like. We can choose male, female. And then we're going to select order details. Basically, this is my lab prescription. So I'll be able to, this is, and you saw me do that Azento case. The format is basically the same. If I wanted to send a case to Atlantis for Azento, then under my order details, I would choose Azento. If I wanted to choose a Simplant surgical guide, I could do that. But now I'm just choosing an Atlantis restoration. So we'll simply click on Atlantis. And then the last piece of information that I need is a date that I want this back. You can pick anything you want. They'll give it to you when they're ready to give it to you, which is approximately 48 hours. And then we're just going to hit submit. Once I hit submit, they now have it within seconds. You'll get an email that says that they have it, it's ready to go. And you can start taking a look, and you can basically design everything. And I'll just go quickly through this. For those of you that haven't used an Atlantis abutment, it's insanely good. Those are the best custom abutments on the market. The contours, you can have either a titanium, you can have gold colored titanium, or you can have a zirconia abutment. So the premise behind all of this is that you're going to order that abutment from them via a scan, and that abutment is going to cost about $200. They're going to send you a core file, and that core file, again, you can make in-house. You can send it to your lab, or you can just have Atlantis and say, hey, you guys just make the crown for me. So what blows me away every single time is I made this crown before the abutment was ever created. I made this crown off of that virtual core file, and the fit is just insane. It's just perfect because we're dealing with virtual digital files, and they work incredibly well. As I mentioned, we're going to purchase an IO flow, and you'll just purchase these as you would any sort of an impression coping for your brand of implant and platform size. And then once I start filling out my prescription, the cool thing about this is that with a custom abutment, I used to order custom abutments, and give me just a couple more minutes here, guys. I used to order custom abutments from the lab, and I'd get it back, and darn it, the mesial and distal margins were like 2 to 3 millimeters subgingival. I'm like, okay, well, that was sort of the reason why I ordered a custom abutment is I'm going to cement this thing, and I don't want to dig for cement. And now you've kind of made it hard for me. So the really nice thing about this script is I can say exactly where I want those margins, where I want them positioned, how deep I want them in all surfaces around that implant. I can talk about my contours. Do I want this to be a concave or a convex type of a situation? I can also describe how much pressure do I want. We all have those situations where you get the abutment back from the lab and you go to put it in, and the patient says, are you going to numb me? And my response is, sorry about the fire truck here. My response is, do I have to numb you? Well, I don't know. How much pressure can you take? How much pain can you take? Because sometimes it's a lot. Well, here I can dictate to Atlantis and say exactly how much tissue pressure I want. So I know. So that the default setting is to contour tissue, which will apply about 1 millimeter of pressure on the tissue, just enough to blanch it. But the patient doesn't have pain with that. And that typically works out quite nicely. And this is important because a lot of times when you're sending this to the lab or you're doing it on your own, we don't really look at the contours of the abutments, but there have been some really interesting studies that have been coming out that talk about the idea of making the emergence of the abutment. If the emergence of the abutment, I'll get to your question in just one second. If the emergence of your abutment is greater than 30 degrees, meaning that you have a convex abutment coming off of your implant, the risk of peri-implantitis goes up insanely high. So there's something about like a 37% risk of peri-implantitis with abutments that come off with greater than 30 degree emergence or a convex emergence. So we want that to be concave. Question is, can you use the same system for screw retained crowns? I will show you. The answer is yes, and you'll see in just a second here, because you can do cement or you can do screw retain. So once I submit the case, they're going to send me an email saying, hey, your file is ready, take a look at it. This is just a different case, but the idea is the same. So I can just log into their site, and I'm going to be able to look at the crown that they virtually designed. I can look at the abutment they designed. I can take the lower jaw, in this case, and make it somewhat translucent. And if I make it translucent, then I can appreciate exactly how deep that margin is going all the way around. So I can visualize all this. I can look at it. If I like it, I approve it. If I don't, then I change it. I can open an editor and just change that, and I can deal with all of that. So if I change it, I can raise things up depending on minimal thickness and anything that I want to do for it. And then again, I'm going to get an email that says, hey, here's your core file. You're ready to go. And with the core file, I'll be able to go ahead and design the restoration. So I mentioned that I'm going to send this to, or you guys, if you're only doing digital imaging, or you're going to send this to a lab. But since I got the question about a screw retain restoration, well, since you asked, that was well placed and timely. I'll just show you what it looks like when I get that core file into my office and how long and how difficult it is for me to design this. Basically, it already has a margin drawn all the way around here. So all I'm going to do is open the file and hit design. Once I hit design, the software is going to calculate a crown that's going to fit on top of that abutment. Now I can spend, and beyond the scope of what we're talking about here, but I can go through all of the design. I can adjust the contours. I can adjust the occlusion. I can make my way all the way through that. I'll just speed this up for time here. And then one of the last things after I'm finished designing this is I can see where that screw access channel is going to be, and then I can just use some tools to create a dimple or a screw access channel in my restoration. Now, if I sent this to the lab, they would just do this for me. They would design the screw channel, but it's basically going to give me something where I've created that dimple, and now we can manufacture that restoration that is basically going to almost have a hole in it. We still manually punch through. So here's my milled restoration and the abutment that came back from Atlantis. Again, the lab would just be doing that for you. And then we just put these two pieces together. And basically what I'm going to do is screw my crown, take my crown and put it onto my abutment extraorally. And then I'll just screw that into the mouth. So we're cementing these two pieces extraorally, and then this is just going to torque into the mouth as one complex. If you get a screw retain restoration from your lab, they're doing this exact same process. They're doing the same thing. They're just cementing the abutment to the crown extraorally and sending it to you. If you're manufacturing it with Atlantis, then yes, you would just do the same thing on your own, and then you have your final restoration. And I'm 1 minute over my time. So in the last 10 minutes, we had one question. Any other questions that we have here? And basically what I want you guys to get from this, and workflows and things that I want you to understand from this, is that it's more than just a piece of equipment. When you're dealing with digital imaging, it's, okay, fine, I want to get into digital imaging. Well, what are you going to do with that? You can, for example, you can buy the best impression material in the world, and you bought this impression material and you made this incredible impression. Well, that impression is meaningless to you unless you send it to the best lab in the world. So it's not about just getting an image. It's what are you going to do with that image? Now, with a prime scan, you're going to create that level of accuracy, and that opens the door to basically make anything. I can make partial dentures. I don't actually own physical impression material in my office. I don't own stone. I don't own plaster. I just don't have it. I just don't have a need for it, because everything is going to be imaged. Everything is going to be exported as an STL and printed or sent to a lab that will take care of those sort of things. So that's it in a nutshell. My email is here at CDOC. So if you have questions that you don't want to ask live at this time, please feel free to reach out. Can you show where the 30 degrees is for the emergence profile? So what I was referring to when I was talking about 30 degrees, and the study that I was referencing here was talking about, and I should have included another photo. I don't believe I have that photo in this presentation. So what this is referring to, what this was looking at, they looked at bone level implants, not tissue level implants, and they were measuring. So you've got your platform of your implant, and they were measuring the angle that the abutment came off of the platform of your implant. And if that angle was greater than 30 degrees, which would basically create a convex emergence of your abutment, that's where they found high levels of peri-implantitis. They found approximately 37% peri-implantitis in those situations. As that angle shrunk and you went less than 30 degrees, well, then your emergence narrowed and you basically had a concave. So the takeaway from that, don't remember the 30 degrees. You're looking for a nice concave emergence of your abutment to help avoid that. Other questions?
Not seeing any, but I know on the last webinar you did for us, someone asked about like continuing education in CDOCs. Not sure if you want to go a little into that.
Yeah, I mean, look, when it comes down to this stuff, you make a significant investment in equipment. And yes, I'm biased because I'm faculty for CDOCs, but I also happen to believe that it's the greatest education center in the world. One of the cool things is that when you invest in technology through Dentsply Sirona, they will include the training and the education that you need. And that's something that can happen through CDOCs. And so, it's one thing to spend all the money, but if you're not going to on the equipment to buy it, but if it's going to sit in the corner because you don't understand how to fully utilize it, then there's no benefit to you. So having access to that education as it's included in your purchases is going to be huge. And it's not just about learning to do digital imaging. It's taking all of these workflows on the implant side, on the crown and bridge side, all of those, and being able to train and learn about those as well. So you have access to all of that information and to look at that. If you want to learn more about this stuff, I would certainly reach out to your Henry Schein reps. They can talk to you about it. They can demo this stuff. You can log on to CDocs and take a look at some of the stuff we have going on in there as well. When would you do an anatomical abutment option? So an anatomical abutment option, this is the question relates to when I choose a anatomical, when I choose my abutment through Atlantis. And again, the default setting is that it's going to put up to 1 millimeter of pressure to contour the tissue. And anatomical support is kind of interesting. And I like it because it's going to have a full contoured crown, but it's going to have a very narrow emergence if I haven't developed my tissue. The upside of that is that it's going to be easier. I'm going to have a fully supported ceramic with my abutment because it's full contour. The downside is that it raises that margin up basically equigingival. So I like them a lot in posterior areas that are not aesthetic because you're more likely than not going to be able to see that margin just a little bit. But I would never use it for an anterior restoration. Do you 3D print surgical guides or mill them? What are pros and cons of each? The answer is yes. I do both. Generally, my personal preference is to mill them because a block is going to be about $50, and I know that the precision and the fit is going to be 100% accurate with no room for error in it. I do 3D print as well. The problem with milling is that you can only mill it with one guide hole. For the equipment for the prime mill and the MCXLs that we have access to on the CEREC side, you can only mill one guide hole. So if I need multiple guide holes, then I do need to print it. And those can be incredibly accurate. I like them very, very much, and they work incredibly well, but your processing has to be perfect. You have to clean them properly. You have to photo cure them properly. If you leave a little excess resin or cure them inappropriately, then the guide hole can shrink and you can have fit issues. If you haven't calibrated your resin, you can have issues. So it can be an incredibly accurate, and it is an incredibly accurate process that I use all the time in my practice, but I have to pay closer attention to make sure that the fit and the accuracy is going to be there, whereas milling is typically a no-brainer. There's nothing to do with it. Anything else?
Not seeing anything. I think we'll wrap a few minutes early tonight. All right. Well, thank you, Dr. Butterman. As always, great presentation. And thank you to Dentsply Sirona for sponsoring tonight's webinar. Like Dr. Butterman said, if anyone does have additional questions, please feel free to email Dr. Butterman directly, or you can email us at webinars@henryschein.com. If anyone is interested in attending future Henry Schein webinars, visit henryscheindental.com/webinars for our upcoming schedule. Tonight's webinar was recorded, so it will be sent out within 1 week of tonight. That's it. Everyone have a great night. Thanks for attending.
Thank you.